Today's topic is about mechanism of ventilation. First, let us understand what ventilation is. Ventilation comprises of two processes, that is inspiration and expiration. We will see these structures briefly just to understand how these structures can contribute to the changes in ventilation. The structures are diaphragm, intercostal muscles, thoracic cavity, and accessory muscles of inspiration. Let us first start with diaphragm. The diaphragm is a dome-shaped, musculo-tendinous partition between the thorax and the abdomen. Contraction of its muscle fibers causes a descent of its central tendinous portion, increasing the vertical diameter of the thoracic cage. The effectiveness of diaphragm in increasing the dimensions of the chest depends on the strength of its contraction and shape of the diaphragm when relaxed. The effectiveness of diaphragm is decreased by paralysis of diaphragm, pregnancy, extreme obesity, tight abdominal garments, and the disease emphysema, which I will discuss in upcoming video. The nerve supply to the diaphragm is the phrenic nerves, which arises from cervical cord segments 3, 4, and 5. This knowledge is important because any spinal cord injury above C5 is immediately fatal because all the respiratory muscles are paralyzed. On the other hand, a patient with spinal cord injury below C5 can breathe almost normally because of the intact function of diaphragm. Next we will look at intercostal muscles. The word inter means in between and costal means ribs, so intercostal means muscle between the ribs. These muscles occupy 11 intercostal spaces and are supplied by motor nerves from the anterior rami of 7th to the 11th spinal nerves. The intercostal muscles are attached to the adjacent ribs. If they contract, they pull the upper rib downward and the lower rib upward. Let us take the example of external intercostal muscle. The fibers of external intercostal muscles slope downward and forward. They are attached closer to the pivot on the upper ribs than on the lower ribs. Contraction of the external intercostal muscles during inspiration tends to elevate all the remaining lower ribs. Elevation of the ribs pushes the sternum diameter of thorax. Elevation of the ribs increases outwards, thereby increasing the anteroposterior and the lateral diameter also. This workings does not apply on the first rib because the first rib is relatively fixed in position. The reverse is true for the action of internal intercostal muscles. They slope downward and backward, therefore creating a longer force arm for the upper rib. Hence, their contraction tends to pull all the ribs downwards. I know this action of intercostal muscle is very confusing. However, the good news is in clinical setting, detailed action of the intercostal muscle is not important. I will give what is important for exams and what needs to be remembered, so stay till the end of this video. Lastly, we will look at accessory muscles of respiration. There are two accessory muscles of respiration that are scalene muscles and sternocleidomastoids. The scalene muscle is attached to the first two ribs and the sternocleidomastoid are attached to the top of the sternum. Their action is to elevate the thoracic cage. Why they are called as accessory muscle? It is because they do not contract during quiet breathing. However, in deep breathing, they contract vigorously. In respiratory disease, you will notice visible contraction of these muscles in a patient. That means the patient is having breathing difficulty. Now, after we have covered the structures, the processes are simple to understand and remember. Let us first start with inspiration. During inspiration, the diaphragm and the external intercostal muscles contracts. This causes the thoracic cavity enlarges. When thoracic cavity enlarges, pressure of the cavity is reduced compared to the external pressure. This difference of pressure causes the outside air to rush into the lungs. Whatever changes in inspiration, expiration is the reverse of it. However, in quiet breathing, expiration is a passive process. The volume of the thorax is decreased by relaxation of the diaphragm and external intercostal muscles. In deep breathing, expiration becomes an active process. A number of expiratory muscles, like internal intercostal and abdominal muscles, are involved in active expiratory process. Contraction of abdominal muscles like the rectus, transversalis, oblique increases the intra-abdominal pressure. The intra-abdominal pressure pushes the diaphragm upwards, pulls the ribs downward and medially and fixes the lower ribs. Consequently, contraction of the internal intercostal muscles lowers the ribs. Besides their role in deep breathing, the expiratory muscles are involved in other forced expiratory efforts like coughing, vomiting, defecation and Valsalva maneuver, etc. Now I will tell you what is important and why is it important in clinical. What is discussed as extra will be a resource for your academic exams only. You must remember the mechanism of inspiration and expiration, the structures that can be affected in breathing disease. For example, if you see a patient's accessory muscle is visibly contracting, what does it tell you? It tells you the patient is having breathing problem. That's all is important and the extra details will be useful for written exams. These are some questions that can test your remembrance of the topic. Pause this video and try to answer them. That's all regarding the mechanism of respiration. If you find value in this video, please like, comment, and subscribe as this will motivate me into doing more videos like this. If you have any biology topics that need discussion, send them via the Google form that I have linked below.